Okay, good morning everyone. Thank you so much for joining us this morning for this session, Falls Prevention in Greater Manchester, delivering integration and reconditioning. Welcome, I hope you've had a really good week and looking forward to this morning's session with a great panel of speakers and participants and panellists. So my name is Hayley Lever. I'm the Chief Executive at Greater Sport and Exec Lead for GM Moving, which is our Greater Manchester strategy for physical activity and our shared movement for movement. And this piece of work is just hugely important to my work and to the work of people around Greater Manchester in every sector and every part of the system and community. It's been such a privilege to see the work develop, and I wanted to start with a big thank you and congratulations to everyone who has contributed to this so far during a hugely demanding time. And thank you to all of you for joining today to be ready to play your part in the delivery of the next phase of our work as we deliver integration and reconditioning together. So just a bit of housekeeping to start with. Please do use the hashtags. If you're on Twitter and social media, please use the hashtags in the chat there, GM Falls Prevention and GM Reconditioning, so that we can keep track of the conversation, engage people outside of the room and keep the conversation growing, rippling out into the days and weeks ahead. Please do feel free to use the chat, send in questions or comments or thoughts and connections to the panelists and the speakers who'll be able to respond to you. And obviously we can pick up some questions in the panel session as well. Unfortunately, Suzanne Hilton, who was going to chair the session today, is unable to attend due to personal circumstances, and she does pass on her sincere apologies as she would have loved to chair this session. Suzanne is a passionate advocate for falls prevention through her role as CEO of Bolton Age UK and the chair of the GM Age UK collective. And she's really aware of the prime importance of primary prevention, and we're all aware of the role that the BCSE, the such important role that the BCSE sector play in this work. So I'm really sorry that Suzanne can't be here today, and I hope I do the work justice in her absence. So this event is to share the latest thinking, the developments and activities which have been happening across a range of stakeholders and localities throughout 2021, with a view to deliver an ageing well integrated approach to falls prevention and reconditioning in 2022 and beyond. The event has been driven by a really collaborative partnership, which I've loved watching in action. It includes senior leaders and colleagues based in the Healthy Ageing Research Group at the University of Manchester, Greater Sport, Greater Manchester Ageing Hub, GM Health and Social Care Partnership, including the Frailty Care Reference Group and Adult Social Care Transformation, all the Greater Manchester local authorities and voluntary and community sector organisations. So a real whole system approach to something which is so important to every community across the city region. The GM Falls report is a brilliant piece of work, and the process of getting here and bringing together the system to understand how this works have been of real value in itself. And we are delighted to welcome a number of excellent speakers and panellists today who are going to cover the impact of COVID-19 pandemic on deconditioning, on falls, and on the GM vision and response for falls prevention, which we can all work on together. So first of all, we're going to start the event hearing from Dr. Oliver Rashbrook Cooper from the Office for Health Improvement and Disparities, who co-authored the recent report, The Wider Impact of COVID-19 on Physical Activity, Deconditioning and Falls in Older Adults. He will be sharing the headlines from the report, plus some key recommendations for recovery. So over to you, Oliver.
Thank you very much. Really looking forward to this event, and thank you for inviting me to speak. I'm just going to give some of the background about the relationship between COVID-19, physical activity, deconditioning, falls in older adults. I am working at the Office for Health Improvement and Disparities, which is the health improvement parts of PHE, former PHE, combined with some departments from the Department of Health, just in case anyone wasn't aware of what OHID is. And I work in the Healthy Aging team, and we, together with the Health Economics and Modelling team, wrote this report, Wider Impacts of COVID-19, modelling the impact of strength and balance activity reduction on the risk of falls. So to start with some background, the relationship between COVID-19 and deconditioning. COVID-19 has affected almost every aspect of all of our lives, and these wider impacts will have consequences for a range of health outcomes. You can see this quite complicated diagram on the right-hand side. Details of this aren't really important, but it's just to illustrate the complexity of the relationship between all of the effects of COVID-19 and the indirect effects of things like the lockdown measures, restrictions upon transport, people's staying at home, engaging in fewer activities than they previously did, is likely to have effects upon morbidity and mortality. So evidence has suggested that some of the wider impacts of COVID-19 have affected older people's physical and mental health disproportionately, with one of those most acute impacts being the reduction in physical activity leading to deconditioning, where deconditioning is physical, psychological, and functional decline. So a lot of older people reduced their levels of physical activity, and that's likely to have impacts on a range of different health outcomes. The physical activity levels, in particular strength and balance activity, were reduced during the COVID-19 lockdowns, but that reduction seems to have persisted despite restrictions being relaxed. So even though some of the barriers have been removed to physical activity, lots of people are still not doing the levels of physical activity that they used to do. So when we look in detail at the effect of COVID-19 upon physical activity, broadly speaking, we can see that levels of physical activity amongst older adults, which is people aged 65 plus, have fallen during the pandemic and after the pandemic. But when we look at the kinds of physical activity people are engaged in a bit more detail, we can see that the biggest declines we're seeing in strength and balance activity, things that improve your strength, things that improve your balance, and things which will ultimately reduce your risk of falls if you engage in them. So our report showed that in 2020, the average duration of strength and balance activity per week decreased from 126 minutes on average to 77 minutes compared to the year before, which is a 40% reduction. It's a very sizable reduction in strength and balance activity. And so we decided to look into the effect that would have on falls, which I'll come to a little bit later. When you look in more detail about who was affected by the reduction in physical activity, what we saw was about 25% of older adults reported doing more, about 40% reported doing the same, and about 35% reported doing less. So people weren't affected equally by the pandemic. And in the initial stages in particular, some people took it as an opportunity to do more. But obviously, that has been outweighed by the large number of people doing less. When we think about who is more likely to have been affected by the decrease in physical activity, we find that it's a long list of people from all different kinds of backgrounds. People from more deprived backgrounds, women were affected more than men, people from Black, Asian, and other minority ethnic backgrounds were more likely to have seen a decrease in physical activity, people from urban areas, people who shielded, people living with long-term health conditions, people living with multi-morbidity, people living with dementia, and people living in social care settings. So those are the groups where you expect to see a greater decline in physical activity, and as a result, more chance that they will have experienced deconditioning, the reduction in physical, mental, and functional capacity. So the impacts of deconditioning are the following. So we can divide it into medium and long-term impacts, which are effects upon chronic and non-communicable disease and also falls. So you'd expect in the medium and long term to see an increase in falls, an increase in depression, increase in type 2 diabetes, increase in cardiovascular disease, and an increase in musculoskeletal problems. But as well as those medium and long term impacts upon morbidity, you would also expect to see these more immediate impacts upon functional capacity. And these are really well illustrated by a 2021 Age UK study on the impact of COVID-19 on older people's mental and physical health. So some of the more striking findings from that were that since the start of the pandemic, 26% of older adults report being unable to walk as far as before, and 18% of older adults report feeling less steady on their feet. And following on from that theme about who was affected, we also see from that survey that these changes are more pronounced amongst people with long-term health conditions or more disadvantaged socioeconomic backgrounds. So to illustrate that, 22% of older people from more disadvantaged socioeconomic backgrounds say they feel less steady on their feet compared to 14% from the most advantaged. So again, there's an inequality not only in physical activity, but in these kind of early signs of deconditioning. So in our report that was published last year, back when we were PHE rather than OHID, we modeled the potential national impact of reduced strength and balance activity on falls. And the modeling that we did there put the number of projected additional falls nationally at over 250,000 per year. which was we predicted would lead to costs to the health and social care system of 210 million per year. So if you break down the usual healthcare pathways for those 250,000 falls, it's plausible that you'd end up with nearly 26,000 people requiring a GP visit, 30,000 requiring an ambulance call out, 14,000 requiring an inpatient stay, and 12,000 requiring a care home package. So again, those are the national figures from our report. And the modelling in that report predicts that those figures will continue each year for as long as the reduction in physical activity as a result of the pandemic persists. So every year, for as long as people maintain the levels, the lower levels that we saw after the pandemic began, you'd expect this additional number of falls to happen each year. So I'm finally going to finish with the recommendations that we had that we set out in the report, which we put together in consultation with a group of expert advisors. So we had two different types of recommendations: whole population recommendations and more targeted ones as well. So the measures aimed at the whole older adult population, the general population, were to promote awareness of deconditioning and the need to gradually build up activity levels to older adults, unpaid carers, and also health and social care professionals, to increase access and promotion of strength and balance activities for all, to ensure falls prevention activities are promoted using positive messaging, where that means thinking about the benefits of strength and balance activity, for example, rather than the risks of falls, aiming these at specific communities and emphasizing the benefits of strength and balance for well-being, and as well as safely resuming previous activities that people engaged in before the pandemic began. And the targeted measures were looking at individuals with appreciable functional loss or transition towards frailty, who require support from rehabilitation, falls, and physiotherapy services, and also thinking about measures for people who've suffered deconditioning as a result of post-acute COVID-19 syndrome, also known as long COVID. They would require support from post-acute COVID-19 syndrome NHS services. So finally, to finish on a positive note, the work that we did in this report has been selected for inclusion in the prevention strand of the Adult Social Care White Paper, which commits to funding of 3 million over 3 years to pilot new ways of addressing deconditioning, as well as to set up a deconditioning network to find and share good practice. One example of good practice, of course, would be the stuff we're going to find out about today, falls prevention in Greater Manchester. So on that note, I'd like to hand over to the next speaker. And yeah, thanks again for having me here. Looking forward to finding out more about this wonderful project.
Thanks, Oliver. That's fantastic. And I was just reflecting as you were talking there on the engagement process we did around the GM Moving in Action strategy last year, where we asked people to talk in engagement sessions about how moving has mattered to them and their families, their communities, and their colleagues during the pandemic. And I was really struck at the time, and again, just by what you were saying there, and how people shared deeply personal stories of the deconditioning vacancy in their family members and neighbours during the pandemic. And obviously, there's lots we can do together to, and have begun to do already, to rebuild from that. But it has been a huge impact, and as you can see from all of the slides, a real disproportionate impact on certain groups. So we're going to pass over to Jamil Abdul-Kader this morning next, who's an expert in the room by lived experience from Greater Manchester Older People's Network. Jamil is from East Africa and Asia. He's lived in Manchester since 1971 and is a member of the Age Friendly Manchester Board, as well as the GM Older People's Network. He's lived in South Manchester for over 50 years and is involved in a lot of local projects across the city, supporting real change for the better. So we've asked Jamil to share his personal thoughts and reflections on this work and what it means for the people of Greater Manchester. Over to you, Jamil.
Thank you, Hayley. Good morning, all. My experience with falls is because of my mum and my mother-in-law. Both were over 80 and suffered from dementia in later life. Both had history of falls, both at home and in hospitals. Falls do not happen overnight, but they gradually creep up on you like your age. Falls hurt, and when they happen, they drain a person of his or her confidence, and then who are afraid to move about even in their own homes or to get out at all. And the concoction of medicine they usually have at that age doesn't help either. Once they stop going out and moving about, then it is a steep downward slope leading to complete inactivity and other complications. Ideally, prevention should start before they become frail. That's where we need people like yourselves who have some sort of structures to help keep people from falling in the first place, and if they do, help them to regain strength and confidence to go back to normal life. During COVID, a lot of people have been imprisoned in their own homes because of illness, disability, family circumstances, and of course the government. At Leventhulme Inspire, where I'm a trustee, we have noticed that those who suffered most were the vulnerable, the very old, disabled, housebound, and sadly, mostly from families with low income, learning difficulties, language and cultural disadvantages. During the pandemic, people have lost their motivation, confidence, and mobility because they've been cooped up inside their home for months. Older people don't have membership to expensive gyms. Their only exercise was to walk everywhere, go to shops, go to parks, walking. Personally, I've been attending so many Zoom meetings at home that now I realize that I cannot walk as much as I could before. Even walking to the bus stop is hard work. I have an exercise bike at home. I use it to hang my clothes on. We have been trying to get people to come out by ringing them, door knocking, and encouraging them to come out, even if it's up to their own garden. Our lifestyles have changed a lot, and we do things differently. We have to get used to the new norm. First, prevention, information, and training should be aimed at the whole person, including the carers, relatives, friends, and all those who come in contact with a person. It could be in the home, in the community, neighborhood, centers like Inspire, and care homes. Campaigns like Keeping Well this winter booklet were excellent because they had lots of sound advice and were freely available to all. The exercises in them were aimed at individuals who could do them in the privacy of their homes as and when they felt like doing them. No pressure. Falls prevention is a priority in Greater Manchester, and I hope this event, with its latest thinking, developments and activities, will be shared and adopted by all. Most of all because I'm in it. Thank you all for giving me this opportunity to speak. Thank you.
Thank you, Jamil. And Jamil will be on the panel later as well to take any questions. And please do, if you've got any questions about anything that any of the speakers have said, please pop them in the chat and we'll collect them together and share later on in the panel session. I think, you know, what Jamil was talking about there reminded me of just how important the everyday movement is within the home and within the community, and just how, as you've said, people did lose motivation and confidence. I've certainly seen that in my family members, and the ability to go out. And it's not easy even now to begin to go out and to regain that confidence and motivation, particularly during the winter. And the work that everyone did last year was fantastic on keeping well in winter, and we do need to keep those messages and keep that support going in the community as well. So thanks so much, Jamil, for joining us this morning, and look forward to hearing from you again later on. We're going to move to Jane McDermott next, who's the Senior Programme Manager for the NIHR Older People and Clinical Frailty Policy Research Group, as well as leading on strategic relations and impact for the Healthy Ageing Research Group. Jane is incredibly passionate and energetic for the Force agenda, and she's been working in this space for several years. She's a real force to work with, and it's been fantastic to work with you this last few months, Jane. Jane will cover the background of the GM4's consultation with the key stakeholders across both clinical and community pathways, creating a series of recommendations for the system that we can work together on. So over to you, Jane.
Thank you, Hayley. So as Hayley just touched on to then, I'm going to talk about prevention of falls and enablement of reconditioning for GM residents. This builds upon insight that has been gained from a number of pieces of work carried out and delivered in partnership by the Healthy Ageing Research Group based at the University of Manchester, Greater Sport, but all of which has been supported by the Ageing Hub and the Health and Social Care Partnership. The report launched today, which I think we will be putting in the chat shortly, includes information and insight based on a consultation we've undertaken that aim to understand activity in relation to falls prevention practice, pathways, evidence-based strength and balance interventions across the GM ecosystem. In particular, to understand what works well, what were the challenges, but also how provision was commissioned, as well as to understand the impact of the pandemic in a broader sense. We also wanted to explore potential interest, ideas, and a remit for a proposed GM Falls Collaborative, with a view to raise the profile and prioritise falls prevention across the city region. So I'm just going to offer a little bit of a picture on the consultation and process and timeline. This work builds upon activity undertaken from the Healthy Ageing Research Group, which was back in 2019, which was commissioned by the Centre for Ageing Better, raising the bar on strength and balance, which really highlighted the absolute importance of whole system integrated approaches, the importance of evidence-based interventions and falls prevention across the life course. We delivered a series of national roadshows in partnership with PHE, now OHID, one of which was in GM. They're all around the time that the CMO physical activity guidelines, which really raised the profile and importance of strength and balance for ageing well. Building on this work, we partnered with Greater Sport and began a series of consultations and workshops, mainly with the aimed at voluntary, community, fitness and leisure sector, with a commitment to both deliver on the recommendations from raising the bar, but also to integrate strength and balance from midlife and taking a much more life course prevention approach. However, the pandemic hit, as we all know, and as a result of the conversations we were having both locally and nationally on the potential impact of lockdown measures, especially for those who are asked to self-isolate, shield, on physical deconditioning and strength and balance, as Oliver just highlighted, and to hear the stories of Jamil as well, we pivoted this work at pace. We broadened the collaboration within the wider ecosystem, but critically, the GM Ageing Hub age-friendly city region infrastructure, including the Greater Manchester Older People's Network, helped us ensure then we moved into the Keeping Well campaigns. So we delivered the Keeping Well at Home campaign, we then evaluated that and we updated it and improved it, and then we delivered the Keeping Well This Winter campaign. All part of the story that Jamil just touched on then about trying to enable people to maintain and keep well whilst at home during lockdown. So it wasn't until April 2021 that we then moved from our original ambitions and commenced this piece of work, which included a series of interviews, workshops with more than 150 stakeholders from across the GM footprint with all of our 10 local authorities. Interviews included health and social care practitioners, NHS strategic leads, commissioners, public health, voluntary community sector representatives. We also then did a series of workshops, and this included a really broad spectrum of the wider population and communities, so housing, employment, transport, academia, but especially and most importantly, those with lived experience, which included Jamil. In addition to this, we also started to map the system to try and understand what were the pathways, what was the provision, what was the practice locally, to really give us a really good, rich picture. We drafted the initial report and the recommendations, which we then sense checked with all our stakeholders. And simultaneously, we also established a working group, which included Paul McGarry from the Ageing Hub, Warren Heppelet from the Partnership, Hayley Lever from Greater Sport, Beth Mitchell, who you've heard of, also Jason Bergen and myself. And this working group really offered a strategic framework through which to understand what was working well, but also to acknowledge and amplify the challenges that need to sit at the forefront of preventative, integrated health, care and community frameworks to support ageing in place. It did also enable us to effectively strategically align with the ageing well priorities, and that includes the work that Debbie, also Martin will be sharing, as well as the development of the GMICS, active ageing priorities, and bringing the healthy ageing research activity, all of which are working towards delivering integration and reconditioning. So that brings us on to the report today. which is being launched, which I think should be in your chat, hopefully. There'll be a link, so there's an exec summary. I'm just going to touch on some of the highlights. We don't have lots of time, and this is just some of the headlines. So in terms of the themes arising from the consultation, in relation to the GM ecosystem, and as a result of the health and social care devolution, all 10 localities described working towards greater integration of services, both strategically and operationally. This really builds upon the extensive work that's taken place within and across the partnership over the past 4 years. All that learning and insight gained from an evolving integrated ecosystem is invaluable. However, there was recognition that in terms of falls prevention, strategy, priority, services, pathways, information and guidance on falls was somewhat different between, and in some cases within, localities. When thinking about prevention across the life course, the emphasis of focus and resources was in the main on secondary prevention. And whilst we did discover some really lovely pockets of absolute excellence in terms of primary prevention and community provision, such as people being able to self-refer, also social prescribing playing a really important role towards preventative and proactive life course approaches, it wasn't system-wide. In terms of commissioning, again, some localities had dedicated full commissioning, others had fully integrated systems. The final two themes really around workforce resource and capacity, as well as innovation technology, just really delivered really rich insight in terms of what we need to learn from the pandemic and what it has taught us and how we can take that forward. So in terms of our recommendations, throughout the consultation, there has been an overwhelming support for the establishment of a GM Pause Collaborative, really recognising the need for leadership, capacity, and building on the strengths and aspirations of integration and joint commissioning. The GM Collaborative would include senior leaders and, of course, our experts by experience, with terms of reference to oversee the delivery of the following GM priorities is what we've identified. So equity, access, equality, and this would include a set of GM quality standards and delivering inclusive provision, embedding evidence-based programmes and scaling up. For example, effective implementation, including the fidelity of falls management exercise programmes to ensure the system actually delivers on prevention and reduces falls. Data improvement, so enhancing data insight to inform needs-based commissioning, as well as to identify those residents who would benefit the most. System-wide workforce development, recruitment, training, and delivering on representation targets. Establishing a community of learning, sharing, problem solving to include workshops, and actually the first of which is probably most likely going to take place early in March. Digital technologies that enhance and enable, including test bedding blended models of interventions, building on the learning from the pandemic, for example, the Keep On, Keep Up app, but also being mindful of the digital inequities that sit across the system as well. There is always the cross-cutting priority of changing the narrative, and I think Oliver also touched on this, the need for this proactive shift towards a positive, age-inclusive language and gain framing to reduce stigma and overcome ageism. So all of this work is going to be delivered through a post based within the Ageing Hub, but spanning the falls ecosystem. We will co-create a programme of work aligned to the above, reporting into the Ageing Well Board. So just to offer a little bit of a visual insight, and I kind of scribbled this on a piece of paper and it looks great because a friend, somebody put it together for us. This is what we think it's going to look like, but actually we would really welcome, it's a draft visual, I'd really welcome any thoughts, contribution, any amendments to this to form a next iteration. The plan is that we'll take some feedback on this and then actually we will put it in the exec summary and the report in the next couple of weeks. So finally, the only thing I'd like to say is thank you to everyone who took part in this consultation. Contributions, engagement and support during a time of extreme pressure has really been invaluable, but a special thanks to Beth Mitchell and Jason Bergen. Thank you.
Thank you, Jane. And you're absolutely right. It has been a great, my reflection, I suppose, just listening to what you were saying there, Jane, is about just the way that this work has been done. And you alluded to at the end there, this is an iterative process. It's something we're learning together. And the idea that we can develop communities of practice, both locally and nationally, to really have that open, sharing, collaborating, freely, you know, giving of the resources and things that we all develop together has got to be the way forward when everyone's operating under extreme pressure. And there's so much great learning to spread and grow out there. So, you know, don't underestimate the power of that development of communities of practice. It's really, really important to this work, and what's so great to see such a range of people sharing links and things in the chat today, because this is where it starts really. Our next speaker is Deborah Ward, and she is the Senior Programme Manager for Adult Social Care Programme within the Greater Manchester Health and Social Care Partnership. Deborah's going to be sharing the work and the future planning of the Enhanced Health at Home programme in relation to falls prevention. So over to you, Deborah.
Thank you. Morning, everyone. Yeah, so as Hayley's just been saying, I'm Debbie Ward, and it's lovely to be here today. So I'm going to be sharing a little bit about what we're doing in the partnership and across Greater Manchester, working with all our partners around enhanced health at home and where falls fits into that. But first, I just wanted to give you a flavour of our jigsaw that we call Living Well at Home programme. So this is essentially the transformation that we're delivering across Greater Manchester with that focus around adult social care. And you'll see towards the bottom right-hand side that we've got enhanced health at home there. What we're depicting with this visual is that none of these elements operate in a silo, because nothing does it? So they're all linked together, and we work across underpinning our activity by co-production, working with people like Jamil to make sure that what we're doing is actually going to be the right thing. It's going to work for people in Greater Manchester. We've got our involvement of voluntary and community sector. As Jane was saying, data insights and information is just so important to make informed decisions. So this is what we're looking to do, and then I'll move in a little bit more around enhanced health at home. After I've just mentioned that when we talk about living well at home, it's very much about where that person lives. So right now you can see I'm in my kitchen dining room at home, but that could very well just be someone living in a care home, in supported living, or any residential setting. And our aim really is to make sure that people can live with the best quality of life that they can, as independently and as safely as possible, for as long as suits them. So that's what we mean when we talk about living well at home. So the Enhanced Health at Home stems from the National Ageing Well programme, and I'm sure many of you will be aware that there's 3 strands to that. So we've got urgent community response, obviously enhanced health in care homes, and anticipatory care. Now in Greater Manchester, because we've got that living well at home ambition, we've expanded from enhanced health in care homes to enhanced health across all homes. So we've got that bigger ambition, which we tend to do in Greater Manchester, don't we? So this is the whole of the scope of the Enhanced Health at Home framework, just so that you can see what other elements are included within it. And highlighted in purple is our falls prevention, which has a specific focus around rehab, rehabilitation and reablement, which includes strength and balance, which, as we've just been hearing from previous panelists or speakers rather, is so important. So we've been starting to think about what's already in place in terms of the brilliant work that Jane was just talking about, that we know is happening in and around Greater Manchester, and how can we take that best practice, roll it out further and expand it and improve it to get that better outcomes for people. So to help us understand a little bit about where we're at, we've undertaken what we've called a stock take. So we've gone out to local authority and our clinical commissioning groups to say, where do you think you're at in terms of delivering that core framework requirements for enhanced health at home? And this is the responses that we've had back. So this is from our local partners. This isn't something that we've done in Greater Manchester. So we see that just over a third are in place. They don't need to make any changes. They're happy with their falls prevention elements. However, nearly half, so 42%, are saying it's in place, but it needs some change. So we've definitely got areas of improvement there. And then we've got some which we haven't had a full response from, which is completely understandable given we're in the middle of a pandemic, and some that aren't in place. So the 2 of them make up about 21%. So what we now want to do is finalise the stock take for the ones we're not completely sure about, and then work with people locally to understand where it's working really well in 38% of Greater Manchester. Why is it working well? What have you done? How can we grow that? How can we share the learning and the best practice? And for those where we think it's maybe needs some improvement, how can we help you to do that? So that's what's going to be the focus of our Enhanced Health at Home, is hearing that feedback from everyone. So these are our priority areas. We will have a delivery plan, and that delivery plan will very much be influenced, led, co-designed with the Falls Collaborative that Jane was talking about. So just like that jigsaw at the beginning of my presentation, none of this will be done in silo isolation. We all have to work together to deliver that full model and get that lovely full jigsaw piece. So we'll take the outcome of the locality stock take, as I've said, and then we'll look at prevention, but also response activities as well. So we can't not look at response as well as prevention elements. We've been doing some work thinking about that cross-system strategy, and we've got ongoing engagement on that, and it's really exciting that we're going to be building on that as part of the development. And now we've got the published research results as well. We can start to think about how we can build that into our delivery plan and what that's going to look like. We've been working with the North West Ambulance Service, NWAS, to understand who the highest referrers are. So which care homes, maybe if there's a certain local area where there's more so than others, then do we need to be maybe looking at what's happening in those areas? Are there some technology that might be able to support identifying, seeing when individuals are maybe showing signs that they're deteriorating or in danger of a fall? Or are we seeing individuals that have fallen several times over a certain period? And therefore we need to look again at what their care and support is, and maybe do we need to do a review of their medication? Do we need an MDT approach to figure out what's required? So we've started to use that data, hopefully in an intelligent way, looking at their CQC ratings, thinking about, as I've said, their use of technology, and also understanding what's already in place. And maybe when we're looking across Greater Manchester, seeing those green areas that are doing really well, how can we apply that here so that we can reduce those referrals, but most importantly, reduce the number of falls that are happening? So we've got some work to do around our data, as ever, to understand and really target better those conversations, if I'm honest. And we're working with Health Innovation Manchester and others to understand the implementation and impact of deterioration tools such as Safe Steps. So there's definitely more for us to do on this work in the future. What we're quite excited about is that there's an opportunity for some funding that might be able to support us in our ambition. So NHSX includes technology to prevent falls as one of their priorities. So once we've got that strategy and the funding, yeah, so we'll work together as always to figure out what we're going to do there. But if there's an opportunity, then we'll definitely look at how we might be able to utilise that to gain our ambition. So finally, I just wanted to link back in then to that work that we're doing on our Living Well at Home model and think about how we use the information, the intelligence and everything else to reshape our market. So we know that there's changes that we need to make. We understand that our population is changing. We know that there's more technological improvements that we want to make advantage of. We need to work with our commissioners and our providers to be able to deliver that ambition. So what we're going to be doing is we're looking at a payment and system reform. We're looking at new commissioning models. So how can we take the information, the brilliant work that's being done around falls prevention and feed that into our wider ambition around markets, commissioning and payment and system reform? So thank you so much, and thanks for your patience in bearing with me on my bit of technology. Well, it just completely wiped out, didn't it? But these things.
Brilliant, Deborah. Thank you, and well recovered, as people have said. Yeah, in the chat there between the panelists, everyone's worst fear, but it always comes good in the end. So thank you, and it's a really brilliant presentation. Just such a lot to take in there, and such important stuff. So thank you for that. We're going to move on to Professor Martin Vernon next, who is the consultant geriatrician and clinical advisor for London and Greater Manchester. He's a former NHS clinical director, and he also chairs the Strategic Clinical Network Frailty Care Reference Group. Martin is an expert in the field, and we've been really pleased to have the support of Martin in implementing this work across GM. So over to you, Martin.
Thanks, Hayley. And just really picking up to try and address some of the issues that Deborah left us with at the end there, as to how we might use some of the commissioning frameworks. As Hayley said, I was, I guess, responsible for putting those 3 big chunks of policy in place around anticipatory care, enhanced health and care homes, and urgent community response. And I would say that the thinking in our brains when I was doing this a few years ago was very much around falls prevention at the time. And what's happened over the last year or two has, I think, brought that to the fore. So great to be here, and good to see everybody on the call. So we can go on to the next slide anyway. Yeah, so just quickly then, anticipatory care. When this first arrived in the policy framework, nobody really knew what it was. But as somebody sat in a hospital, actually in the middle of an orthopaedic unit at the moment, this is the pointy end of where people come in with falls and actually sustain something fairly catastrophic in their lives, which what we're about now is trying to use the policy frameworks to grab a hold of people before they end up on an orthopaedic unit with a fracture or an injury. So the question is, how do we do that? Population health management is about taking segments, key segments of the community, and I think the report that Oliver shared with us is really helpful in bringing some focus over that as to who are those people that we think are at greatest risk in our population now. It's then about zoning in on those individuals, and in order to address it, and we heard from Deborah, I think that, you know, in order to address falls prevention, it's actually a system-wide effort. It brings together all parts of the community services, primary care networks. We have 67 in Greater Manchester, social care providers, housing providers, everybody is invested in this. So this really is a paradigm that enables us to get some traction on the whole population in various ways. So if we move on to the next slide. Now, in terms of the investment in this, the NHS puts 20 billion plus pounds into new commissioning models under the long-term plan in 2019. There's 4.5 billion gone into primary care, and some of that is allocated against anticipatory care. As yet, the expectations are to be defined, and I think in Greater Manchester what we're doing, again, we've heard already, GN tends to be ahead of other people. It likes to think bigger and better, and we are already, although this is a paused contractual requirement by NHS England at the moment, we're already thinking really hard about how do we get anticipatory care up and running right now. So although the national expectations are somewhat delayed, we want to get ahead of the curve and use anticipatory care as a means of driving falls prevention for the population across GM. So we'll move on to the next slide. So how do you actually get from Oliver's whole population recommendations right the way down to the sharp end of people who might, if we don't get them before they fall over, end up on an orthopaedic unit or in casualty? And this requires us to segment down the population at risk of COVID deconditioning. We've got people in care homes and we've got people who receive care at home. If we find those cases, we need to do that algorithmically. We have a population of 3 million or so people in Greater Manchester. How do we find the needle in the haystack? Once we've found a group of people who might be in scope for this, and we can segment by key groups such as care homes, care at home, and people who might have been deconditioned, we then need to make sure that those are the right people and match them to the interventions. That requires needs assessment, and then we need to target the right interventions. Some of the things that Deborah was talking about in particular need to be positioned right against those people who are at greatest risk. And most importantly, at the bottom, we need to drive key outcomes. So reducing falls risk, not just reducing falls, and also reducing fear of falling. I see a lot of people who turn up in clinic who are just terrified of having a fall, having either experienced one themselves or their partner may have fallen at home. And this is itself hugely distressing and disabling. So move on to the next slide. So this is really turning the deconditioning report into a real workable model across the whole of Greater Manchester. So strength and balance is therefore a key part of this. We need to find the right people. and particularly thinking about older people who've shielded, people with multi-morbidity, people with living with dementia, people in social care settings, and then make sure that we've got the right groups positioned against those interventions. So these are big macroscopic ambitions, but how do we then turn that into something more real? Move on to the next slide. So in terms of targeting, this is very much then about making sure we've got the right offers in place for individuals. So if we find the right people, we can get the right interventions. And this is why it needs a whole system effort to do this. If we do this alone for anticipatory care, we can then start to pick off other things. And we think this is the absolute priority for the whole of Greater Manchester's anticipatory care programme. Move on to the next one. This is really the business end of the slide. The group that Oliver mentioned in the report, we have a Greater Manchester care record. We have a huge amount of data sat in servers. We can then mine that data set and find people who shielded. There are coded data sets that we can then use, draw together and put a filter over the whole of the 3 million population and get us right down into the detail of the key groups that we think are going to benefit most. And then offer the right interventions to those people. And principally, this sits around these key areas. Exercise, yes. If you want to age well, you need to be more active. We've already heard that. Making sure the environment that person lives in is safe. Making sure that their medical condition is optimized. Often doctors, including myself, do things to people which don't necessarily help them in later life. And sometimes we just need to stop doing some of the things that previously were right and optimize that person's medical treatment to reduce their falls risk. Most importantly, strength and balance training. And that can either be delivered virtually, directly, and we've got lots and lots of different ways of doing that across the whole of GM. And then finally, I don't want to not mention mental health and anxiety as a key part of this, because, as I say, fear of falling is a massively disabling condition for people, and we need to think about people's mental health alongside of this. So it's not just about physical activity, it is also about that person's experience of life and their anxieties and depression that might fall out of that. So final couple of slides. So this is the whole programme really, and it just tries to illustrate the fact that running across from left to right, it's running the searches through the data that we've got, lots and lots of data. We need to use that to now zoom in on the individuals. We need to get those key population segments at greatest risk. We need to make sure that we've got the right people, put the right team around them, and this is a multidisciplinary system-wide effort. We then need to get the right interventions, and we have a huge portfolio menu of interventions that we can position against people right into their communities and in their homes. Most importantly, then, we need to drive the right outcomes for those people. And to do this, we need to pull all of the key system partners together, some of them listed at the bottom there. But as I say, this is not just a health thing, but we can use the health investments to drive some of this. So the final thing from the bottom is the recommendations that we've made through a reference group to Greater Manchester Commissioning, that we absolutely need to drive this model for the whole of the anticipatory care programme around falls prevention. We need to proactively find cases. We've got the data in the system and we're already interrogating that with Health Innovation Manchester. We need to validate cases, and we've got agreement amongst primary care colleagues that we can do this at primary care network level. As I say, there are 67 across GM, so it gets us closer to people's communities. And then we need to start thinking about what are our offers through individual service providers. Yes, the health service, but actually all those other system partners who are absolutely crucial in communities to make this happen. And then finally, we need to be able to evidence what we're doing. We need to see where we're not doing it as well, and we need to deal with some of the disparities across Greater Manchester. So to do that, we need a helicopter oversight of the system, which picks out where things are going really well, building this community of practices that we're talking about earlier, but also picking out areas that are more challenged and need more help, more support, and making sure that we're making the offers more substantial in those areas to deal with those particularly challenged parts of our communities that we're not at present accessing. And that is me. Thank you.
Thanks, Martin. That's fantastic. Such a lot there we can look into in the Q&A as well. So do keep the questions coming into the Q&A section at the bottom of the page, and keep the conversation going in the chat. I'm going to ask you all to just take a little breath right now. You've probably all been sitting very still and listening intently. And if you're able to get up out of your chair, then please do have a bit of a stretch, keep moving. And we're going to ask you to then think about some really good questions ready for our panel. And also we've got a little Menti meter, which if the Greater Sport team could have, there you go, they've just popped in the chat. So if you go on to a device, perhaps move around and go on your phone on menti.com and put in the code that's there in the chat. There is a little question there just for you to get to reflect on what you've heard so far. And the question is, what one word would you use to reflect on what you have heard so far? Okay, so if all the speakers and panelists can also take a short breath, and we are then going to move into the panel session. Some of the people you've met already, but just while we're waiting for people to use the Menti session, we've got some people joining the panel who you haven't met yet, so I'll just talk to you about them. So Steph Butterworth, she is the, I've just written it down somewhere. She is the Director of Adult Social Services at Tameside Council and is the lead for this work for the Greater Manchester Gases Group. We've also got Paul McGarry joining us, who introduced himself in the chat earlier. Paul is the Assistant Director of Public Service Reform. He's the head of the Greater Manchester Ageing Hub at Greater Manchester Combined Authority as well. So welcome to Paul. And we've also got Professor Chris Todd joining the panel. And Chris leads the Healthy Ageing Research Group. He's the Professor of Primary Care and Community Health at the School of Health Sciences at the University of Manchester. The Healthy Ageing Research Group is a group comprising some 40 plus staff and postgraduates, and he's the director of the UK National Institute for Health Research, the Policy Research Unit for Older People and Frailty. He's also the lead for Healthy Ageing at the NIHR Applied Research Collaboration across Greater Manchester, and his work is broadly in health services research related to falls prevention, frailty and activity promotion amongst older people. He's a leading global expert in these fields and has acted as director of a number of European funded projects. So a fantastic panel. We've also got Jamil rejoining us, as well as Dr. Oliver Rushbrook-Cooper and Professor Martin Vernon for the panel session as well. Do we want to share the Menti? Have we got anything in the Menti? There we go. Brilliant. So inspiring, informative, reflective, hopeful, relevant, and very collaborative. I completely agree with that. Awesome. Preventable. Thank you. That's fantastic. Yeah, I've really enjoyed listening in so far too. Okay, so I'm going to start off then with the panel session. I hope you've had a chance to move and stretch and have a think about what you've heard so far. I'm just going to ask each panelist, first of all, to provide their thoughts and reflections, just a couple of minutes to get us into the panel session and some key reflections. And I'll start with Oliver Rushbrook-Cooper, if that's all right.
Yeah, of course. Thank you. Yeah, it was fascinating to hear. The report I was talking about earlier focused more upon recommendations, helpful ideas about where you might want to get to. So it's been really interesting to hear about the actual implementation of this, and it'd be really interesting to see whether we can explore, working and finding out a bit more about this and maybe rolling it out elsewhere if possible. That might be one of the things that our deconditioning network ends up doing. And also the focus on mental health. I didn't really mention that, but that seems like a really important component of things, not just the fear of falls, but thinking about the I suppose, yeah, when I was talking about the restrictions being lifted, but the decline in physical activity remaining. And it seems there's some kind of psychological or mental barrier, I suppose, still for a lot of people, preventing them from doing what they used to do. And that definitely looks like an area that we need further work on to work out what's going to be effective in overcoming the particular set of circumstances we find ourselves in to do this kind of prevention work. So those are my general reflections, but yeah, it's been really, really interesting to hear about. Thank you.
Thanks, Oliver. Yeah, and I thought the point that Martin made about mental health at the end there, that kind of fear and concern and risk, about risk of falls, it was really key. Is there anything else you wanted to say about that, Martin, in terms of your experiences in the work and what you see and hear from people in that respect?
Yeah, I mean, I think particularly during the lockdown period, and I continue to see people during that time face to face as much as I could. It's an overwhelming thing that people are extraordinarily concerned, having been locked up in their houses for the last year or two, that when they venture out, they suddenly realise that the world out there is actually quite a challenging and threatening place for them. And I think that alone then becomes a self-fulfilling prophecy. So it's trying to address that, understand it, acknowledge it. And these are very, very treatable and manageable conditions for people. But unless we actually recognise it in the first place, we're going to end up with people just ending up in a vicious cycle. So I think it's absolutely crucial to get this front and centre. Actually, without good mental health, there is no physical health either.
Yeah, and that's a really good point, and I can relate to that completely, as I'm going to visit my 75-year-old dad tomorrow, and these are all the conversations that we have on an ongoing basis. I'm sure many people can relate to that as well, with family and friends and community where they are. So I'm going to come to Paul next for some overall reflections on this piece of work and what it means for the work that you do.
Well, thanks, Hayley. I'll just respond to the point that Martin made about that the dread that many older people who've been indoors for the last 2 years or so are feeling. We have really real-time data about concessionary travel use, and we know still that something like a third of people who regularly would use the buses aren't using them. So that gives you a kind of interesting data point on to the extent to which older people are getting out and about. I think, it's a significant day for us in Greater Manchester today. You know, this report is, I think, the reflection of an ecosystem that's been built up in the city region over a decade or so, I think. It's a bit like, I'm going to use a really bad analogy, it's a bit like building a good football team. You know, you've got to have all the best players in the best positions. And I think what you've seen today is we've got, you know, a really, really important group of people who have got a shared vision, ambitions, you know, that GM ambition thing, and trust as well between people from different backgrounds and different disciplines. It's that pooling of expertise. And I think when you build an ecosystem like this, there's lots of stuff that we plan, you know, and colleagues have already set that out. But it's all the unplanned stuff that's really interesting and exciting, and things that you never considered or thought about happen because you get people in a room doing things together. And we're lucky in GM that we have this scale. You know, we have such a range of different environments to do the work. I just want to say two other things very briefly, really. One was about place, and the other one really was about ageism. So the place, the neighbourhood, the community in which people live, I think this, again, relates back to the anxiety and mental health and all those things. It's important that we build places, whether it's a physical design of places, or it's about how people feel as they get older, the connections, the power they have in their local community, is so important, I think, to this agenda. And the voices of older people. So we heard Jamil earlier, but that needs to be absolutely central in everything we do on this agenda. And we're building a program of kind of neighborhood projects to do that. The last thing I just wanted to mention was ageism. It's kind of, it's endemic, is ageism across a whole range of institutions and policy gazes and so on. And it seems to me that if we learn one thing from the pandemic, that it is that we have to listen, and I'll say it again, to the voices of different groups of older people and rethink how we build our communities, neighbourhoods and services for the future. So for me, it's quite an emotional time, actually. I didn't feel it. When colleagues started speaking, I was kind of getting a bit upset about it because it's such an amazing piece of work, and the result is inspiring and collaborative and all those words. So I can't wait for us to get going in the next phase of this work to make those impacts and make better lives for for people, and which is why we come to work. So I just really enjoyed this morning.
Thanks, Paul. And I think I've been working in Greater Manchester for about 5 years now, and it's and this piece of work is almost like a microcosm of the way the system works together at its best. It is generally so collaborative, and just brings together the layers really of the neighbourhood, the localities in Greater Manchester, trying to create conditions for that real neighbourhood, person community centred impact. So no, I agree. I think it's just a fantastic sort of launch pad for the next phase, really. I'm going to come to Professor Chris Todd now. What are your thoughts on just how this generally relates to strategic priorities that you see as important for Greater Manchester and beyond?
Thanks very much for asking. Well, the Healthy Ageing Research Group here in Manchester has been working on falls and fall prevention for 20 odd years. And when you introduced me, it's very flattering, but there are great experts actually in the audience today, including Dawn Skelton, who was the person who, while she was here, published the FAME Force Management Exercise paper, which so much of the work that we're involved in and provides evidence for falls prevention is based on. So that's a quick call out for Dawn, who's there. What I really wanted to say is there is huge amounts of evidence that strength and balance exercise works. It's such strong evidence that we're not even thinking these days of comparing strength and balance against doing nothing. Strength and balance is the thing you compare other interventions against, or at least should be if you're doing randomized trials in this area. It's so important that you deliver strength and balance, something like FAME, to the program. And so it has to be challenging, progressive, to dose, regular, and following the evidence. And all too often, I think the report shows this, all too often, we're not able to deliver exactly to the program. And so the evidence has to be followed. I think that this report really sets the scene for rolling out across Greater Manchester and hopefully across the UK generally. And I might even add the world to that, the Greater Manchester lessons, that we can actually introduce population-based programs to change the health and the quality of life and the risks of falling for the population. So like Paul said, this is why we come to work, to try and make a difference. Within the report, there are a number of strategic priorities outlined. So I'm just going to go through those really quickly. There's the priority of equity of access and equality. That's really important. And so we've got to aim at areas of deprivation, areas of our society, of our communities, where there is greater deprivation, greater risk of falls, and try to reverse that. So we've got to be really careful as we roll out to make sure that we do not increase inequalities, but we do the opposite, that we reduce the inequalities in our society. We've got to embed the evidence and evaluate as we go along. So we've got to think about what works carefully. And we've talked about FAME, the falls management exercise, but there are other evidence-based programs, and we should follow those up. We've got a particular piece of work coming up. The National Institute for Health Research has funded a project we're calling Flexi, which is about implementing FAME and evaluating that implementation across Greater Manchester. So it's a great opportunity, I think, for us in GM. Data improvement as another one of these strategic priorities, and the use of the data that we've got in the system. So that there is, for example, the Greater Manchester Shared Care Record, great opportunity for us to see how these programs improve the health of the population. There's a trauma research network, TARN network, which gives us insight into trauma, including falls and fractures that occur from falls. And we really need to use these data sensibly, proactively, to see the degree to which we're working. And we've got a project hopefully coming up which will help us improve the use of those data. Workforce development is incredibly important. That's both recruitment and training. So I'm not going to say much about recruitment, but I think we do have to think very multidisciplinary, in multidisciplinary terms, from medical healthcare professions, but not forget the exercise professions and exercise professionals who are going to be able to offer huge benefits to the system as we introduce these evidence-based programs or roll them out more fully. there's the idea of a community of learning or community of practice, and those are being set up. And we must include people with lived experience of falls and fractures in there. And then finally, the final part of this is the digital technologies. And there are a number of these technologies, and Deborah made the really important point that they've got to be evidence-based. We've got to invest in technologies which are evidence-based. And there are a few of them around us to keep up. Koku app, there's a standing tool work that we've been evaluating. And then Helen Hawley-Hagan, our group, has been developing the Motivate Me and the My Activity apps. So these are some of the apps where there is evidence, but there are other apps without evidence, thousands of them out there. So we've got to really look at the evidence carefully. And we've done a couple of reports within the Policy Research Unit for the Department of Health very recently, and those will become available probably in the next 2 or 3 weeks once the department has given the okay for them to become public knowledge or to go into the public domain. And we got some work during the pandemic about, as we move at pace towards using digital technologies, which ones worked and which ones didn't. So my final word is just to say something about population-based approaches. We really need to think in terms of the whole of our population, quite young people in their 60s, 70s who are going to have more risk in the future. And we've got to think about getting them more active so that we shift the whole of our population's risk of falls and fractures down, not just try and get to that 5% at the top end who are highest at risk. So population shift has got to be part of our strategy in Greater Manchester. And we've thought that for many years, and I know Paul will nod to that. So that's my comments on this report.
Thanks, Chris. And that last point you make there is so important to our work in Greater Sport and the GM Moving in Action strategy, because it is about a whole population approach. And for anybody, and we can pop the links into the chat, but we launched GM Moving strategy last September, and very much in response to the pandemic. And it just take a whole population approach and a whole system approach to supporting active lives for all. And our team and there's just such a lot of work going on right across the system now to really mobilise around the implementation of that strategy. And as you say, it is about everything from early years all the way through to older age. And that's what's so fantastic about the approach we take here in all the work we do together. I'm going to ask Steph to come in next, if that's okay, Steph.
Yeah.
Steph, you've got a particular role in this. It'd be really great to hear how this relates to what you do and what you've seen over the last couple of years as well.
Thank you. Thanks, Al. Yeah, so I suppose the thing that's come across for me this morning, which is really where we start, is this notion of collaboration, really, and that kind of team around the individual or groups of people around the individual. And I think that really is where we get the best benefits for individuals. I think the issue we've got at the moment is we don't know, and I think it's been in a lot of the chat around what's the data telling us, what are we going to find in terms of people's deconditioning, etc. And of course my focus at the moment is on people who live in care homes. So we talk about inequalities, and you know, if you've lived in a care home, you've been subject to a separate set of rules than the rest of the world for the last 2 years, just by dint of the fact that you happen to live in a care home. So in terms of closures of care homes, in terms of people not visiting, in terms of professionals not visiting when there's been outbreaks in care homes. So in terms of the work that we're doing around people who live in care homes or in kind of supported housing, I think you know, this work really is starting to gain traction with us. I think people who have who've been subject to a fall, so have fallen and are waiting for NWAS to visit, for example, and I've been waiting for too long, 8, 9, 10 hours in some occasions. That's a specific piece of work that we need to address, and we're starting to address. I just wanted to pick up Chris's point around the digital technology as well. One of the things we learned really well across Greater Manchester was the way that we could help people in care homes to be protected by the use of digital technology and understanding what was going on for their health, their physical health at that time as well. So I think in terms of the work that we're doing in social care, the key issues for us are collaboration, working across the whole footprint of people that are on this call, including people who use our services and live in our supported homes. Support very much around the individual and designing that individual care plan as part of that enhanced care at home and understanding what's necessary for that individual. The use of the digital technology as a way of keeping in touch with people, a way of understanding very quickly how we can respond, and then the work that we are doing around the real practical work about how we support people to get up off the floor. You know, we work with people who don't live in care homes, so who live in communities, and help them get up and be safe and well and not necessarily get transferred to hospital. And we need to transfer that piece of work into care homes, which we are doing now. That's just started as we move out of the outbreak stage in care homes. So I think those would be my key points at the moment, Hayley. I'm happy to take any more questions.
Thank you. Thanks. Yeah, some really good important points and a particular lens on this, obviously from the care home perspective. I'm going to come back to Jamil now. Jamil, having listened to all of this, what does this mean for you now in your community, do you think?
Well, I endorse this all, of course. Now that the restrictions are over, maybe we'll have more ease to help people out in the right community. Right, you know what it said was right people to the right interventions. This is great, but remember, different places have different needs. There are certain localities where this has to be concentrated. There are others where not so much. Just that, make sure that all of us who do go through all this are included in your conversations. We might not be able to do things, but we can guide you in the right direction. This is all good. I'm glad I was here, and I hope it's all adopted, and let's see results.
Thank you. And I'm just going back to the point that you made earlier on, Jamil, about the kind of the way that this whole pandemic and has impacted on different people in your community differently. Where do you think the priorities are really for you in your community in supporting people to live and age well?
First of all, we need to get people out. That's the main thing, because they're all cooked up. And now you see, the confidence, even traveling on the buses is not there, because I know of people who have stopped going on buses because they see people without masks there. And now that everybody is open, we got this freedom again. People are still worried. I still see people who are sort of still afraid to get out. Another thing is, they've been stagnant in their homes for so long. We need to, you say reconditioning, we need to go into the homes and get these people out. You'll have to work with community centers like us, care homes, where we get in touch with these people physically. We go on the doors and knock them. So this is what's happening. I hope really that whatever we decide in this seminar, there's fusion and we get some results. Thank you.
Thank you. Yeah, such an important point there as well, and such a simple thing, isn't it, to think about where people are and going to meet people where they are and to work alongside people in the community, starting from whatever their position is and what they're able to do. And I think that also ties all back to what Martin was saying earlier about the kind of mental health aspect of this and some of the inhibitors, but also some of the opportunities we've got, because what people are really longing for is that social connection, to meet back up with friends and family and community. And I've certainly seen that in my community here, just how much benefit people have got from the coffee mornings and the things that have started again in the last few months. So it's so important. Some of the simple things can make the biggest difference, I think. I'm just going to open up to the whole panel really for any reflections on the disproportionate impact of the pandemic on different groups within the communities, particularly with relation to kind of falls prevention, and how is this work, do you think, and how is this report really going to help to address those inequalities that we've seen grow during this time? And if you want to just give me a nod or put your hand up if you'd like to come in, that would be great. Anybody's, thank you, Martin. Go on.
So I think one of the things that we've picked up in the work that we're doing in GM is to identify people with cognitive problems. So, yes, the upstream, addressing healthy aging for people in their 40s and 50s, and I'm certainly engaged in that myself. But for people who've already developed cognitive problems, we've seen a really quite worrying acceleration of cognitive decline in lockdown in particular. And these are people who are now unfortunately hitting hospitals quite hard. And we need to get to those people really quite quickly, because a lot of this is actually preventable in that particular groups. And this is why we're keen to use filters over the whole population to, at least in the early years of this program in anticipatory care, I think we need to go after the most vulnerable individuals, because those are people who are also amenable to intervention. We know, for instance, that exercise, strength and balance training appropriately adjusted to the needs of people with cognitive difficulty, be it in their communities or in care homes, does work. So we have to go after those groups really quite assertively. And now this is kind of urgent, I think, and it's a burgeoning problem that's just come out of the woodwork in the last, I would say, 6 to 12 months, that is causing a huge amount of distress and difficulty for individuals, families. So for me at the moment, that would be a real priority area. And this is, as I say, it's wired into the thinking around GM commissioning for anticipatory care already.
Thank you. And just on that, I suppose, on that sort of priority that Martin mentioned there, I wonder, Steph and Paul, if you just wrap up with your sort of reflections on really on, the most vulnerable from a kind of care home and a community perspective. What are the ways into that? What have you seen work really well for those groups?
So I think there's two aspects to this really. I think for some of the things that I've seen work really well, and obviously they've been in short supply during the last 18 months, is that those things that build resilience in the community, those little things that make a difference, that are the things that make people want to get out and about. So things like, the local community centres that are providing some of the stuff that Martin's talked about in terms of exercise and well-being, and, the various classes and offers there. So I think there's something about what works well is a resilient community and things that are in that community that are helping people live good lives at all levels. So I think in terms of some of our people we are supporting at home, these are the things that we encourage people to be part of, as well as getting their care package. It's not just about getting your care package and sitting in waiting for the carer to come again. It is about getting out and about in terms of resilient communities. And that's why it's really crucial that we have this neighbourhood approach to working together, the collaboration, that everybody in the neighbourhood is working to provide a good life for somebody. So for me, that's about when people are living at home. The care homes is probably is slightly different again, because I think we've got a lot of work to do in terms of getting people back to some kind of good life, because as I said earlier, we've had these different rules around people who live in care homes, and I think all of the work around getting people back into the care homes to just to make people well again. You want to see your son, your daughter, your friend, your partner. So having all those visitors coming in and start, as well as the people who are the professionals, and I put that in inverted commas, coming in as well to make sure that we are building up people's health and well-being from that very basic level, really. This is not all about some scientific, medical input. Apologies to all the docs on the call, but it is about that building up that resilience as well, which I know the docs on the call will agree with. So thank you.
No need to apologise. I think you're absolutely right, because at the end of the day, everything you said there just reminds us of our whole approach here, which is about person and community-centred approach, isn't it? And all the tiny conversations and things that go on within people's homes and families and wherever they connect to other people. It's all of the influences that are going to support and enable someone to move more each day. And that is really quite simple in the end, as much as it is complex. So I'm going to come to Paul for a final thought, and then we're going to hear from Warren Hepplett from the Health and Social Care Partnership to wrap us up.
Well, thanks, Hayley. I think Steph covered brilliantly the issues around neighbourhoods and community and the resilience and networks that we need. Just on a very practical level, we've had a group connected to the Ageing Club made up of kind of community development workers and others working on trying to work out what kind of messaging and practical support community organisations and older people will need to get back re-engaged in community organisations and everyday activities. Now, obviously, Omicron came along and pushed that back again, but we are thinking about, I think, a kind of spring into summer type approach, encouraging community organisations to open up again and to encourage older people to get out and about. But we know it's a huge task. So watch this space for that piece of work. It'll be practical and applied. And look forward to, if colleagues want to get involved in that, if they contact me through this meeting, we'll put you in touch with the organisers.
Thank you, Paul. That's great. We're going to come to Warren Hepler next, who is the Executive Lead for Strategy and System Development at Greater Manchester Health and Social Care Partnership. So Warren is responsible for strategy. He chairs the Ageing Well Steering Group, introducing the NHS long-term plan objectives for healthy ageing, as well as being a member of the Greater Manchester Ageing Hub Executive. And Warren is going to provide us with some final reflections on what this means for us and the next steps in our work together. Thanks, Warren.
Thanks, Hayley, and thanks everyone. And it feels like part of my role here, I think, is to kind of take stock of everything that we've heard, and it's been amazing to see the kind of the whole piece come together really after some months of work when we were thinking of where were the critical contributions likely to come from. How do we turn it into something that is a kind of compelling call for action? How do we do that with a level of precision that helps us, guide and support the system on a meaningful response to the challenge that was set out by Oliver at the start, and come up with a system response that means that we can have the kind of reliability that I think Jamil will be challenging us on as we implement. So I guess kind of first of all, we've got to recognise this is a compelling call for action. It's one that we absolutely need to recognise in Greater Manchester's context, but actually recognising that we've got colleagues on this call. I don't know if you've noticed we've got over 400 people on here, covering all parts of England and the UK, and quite a few from beyond in different parts of Europe. So I think what we can say is that actually this is a challenge, the challenge of falls prevention and the risk of falls across a population is a challenge across any system that is looking to support a shift towards integrated care and more preventative care. And we think that's a global movement. And it's almost a kind of a perfect challenge for those of us that are on that journey to kind of integrated, proactive, preventative care. It requires a response which is social as well as medical. And I think we've heard that really, really loud and clear from Paul and Jamil and Steph and colleagues. It requires us to understand what it takes for a system to pivot towards prevention, rather than brace itself to receive the demand and need from a population that comes from a system that isn't ready to organise itself with a significant model of preventative, proactive, anticipatory care. It requires us to think carefully about the disciplines of population health management, as Martin set out, and there are some key disciplines that we're going to need to grow and spread across the system, so we can earn the title of a kind of an anticipatory, proactive, preventative system in Greater Manchester. And significantly, of course, it requires us to recognise the challenge that action which may just be the wrong sort of action if it doesn't balance the universal with the targeted, and doesn't do it in a way which speaks meaningfully to individuals and residents actually being able to engage with the intervention that's offered, as Jamil has set out, means that we increase the risk of raising health inequalities across the system if we don't do it in that in that considered way. So in terms of our response, I think there are two or three things that we would have to look at. I think the things from today that it feels really critical to kind of emphasise is that this is going to be a kind of contact sport, isn't it? This is only going to work with meaningful connections in communities and neighbourhoods. It's only going to work if we are addressing both the targeted and the universal interventions, and it's only going to work in the context of a place like Greater Manchester if we're also really clear that we have to coordinate ourselves to act with consistency. What we can't do is operate a process which is so loose that it risks creating kind of islands of failure in a sea of success. Or the other way around. So we've got to have something that means we've been effective across the whole of Greater Manchester. The things that give me a bit of confidence that we might be able to do that is based on evidence and assets. I think evidence is that this is a kind of core value of the report itself. That means that we've brought together an approach that we think would work, and now it's our responsibility to accept that. And make use of the recommendations. I think our assets are absolutely what we're going to require on now. And we've kind of told that story throughout the course of the morning, haven't we? That actually we're blessed in Greater Manchester that we've got collaborative vehicles like the Ageing Hub and the Older People's Network and a GM Moving as a model support physical activity across a population. We've got Health Innovation Manchester and a real connection between brilliant academics in our universities that are rooted in the communities that they're trying to support and are relevant to the communities that they're trying to support. And we've got brilliant clinicians that step outside of their day job and give us a guide on what would work and what would benefit the population. So I think the critical kind of next steps for us now is to formally accept the challenge, recognise that the recommendations and report are our route map actually from here. So that should be relatively straightforward for us. I think the other thing that I'm sure Jamil won't let us off the hook from is that actually we now need to work with the Older People's Network and the Ageing Hub to hold us accountable in the way that Jamil's articulated, that we've got to apply that test and look back on how effectively we've implemented. And I hope, Jamil, that you'll help us do that and let us know if we're too slow or we're slipping off track. So we're right with you on that, I think. Thanks, Hayley.
I'll be watching.
Thanks, Warren. Yeah, I'm sure Jamil will. Thanks so much for wrapping up that. Some really great points in there. And I think the key thing there is it is a call to action. Okay, the work begins now, continues now. And the key things I suppose I would ask of everyone in the audience here is to download the report. We'll share the link again in the chat. Do plan and design your response to this. Talk about it with your teams. Keep the conversation going outside of this room. I've loved capturing all the chat that's gone on today, but let's take it out of here. So get on Twitter if that's what you do, or LinkedIn, share the report and create a conversation about it in your sphere of influence as well, because that can make massive change happen as well. We will be, this is the soft launch of the Force Collaborative, so we're going to start to build on the work of the Force Collaborative now. We will share all the links that we've put in the chat along the way, along with the slides, along with answers to the questions that have been put in the Q&A. So please don't get that email after the event and just delete it because you haven't got time to read it. Use it, read it, follow up with all the links and the contacts that you've made. And just finally, to say a huge thank you to everyone who's helped to design and deliver today's event, to all the people who've engaged and contributed to the work that's led to this report in the first place, and everyone on the steering group for the work that's delivered it. It has been a real joy to watch. Not my area of expertise either, and I've learned such a lot about how this group have worked together. And in particular, they've been behind the scenes today. There are 4 bits on my screen with a Greater Sport black box on my screen. But Beth Mitchell, she's behind the scenes today, but she's absolutely not been behind the scenes throughout all of this work. She's made a huge contribution to steer and deliver this and keep us all on track during what has been a hugely busy time and a really challenging time for everyone involved. So big thanks to Beth Mitchell and a big thanks to the Greater Sport team who have run the tech beautifully today and kept all the wheels turning. So have a brilliant Friday. Enjoy your weekends when it comes, and do keep moving and keep your families moving too. And I'll see you soon.